Morning. I'm Jana Dejesus. I'm a research resident over at the University of Texas Medical Branch at Galveston. And I want to thank SAGES for the opportunity at the podium to present our outcomes from the common bile duct explorations we've been performing with the assistance of the robotic platform. Oh. Am I pressing the right button? There we go. Okay. I'm going to give a couple of seconds for our disclosure slide. All right, so as previously been mentioned, choledochal lithiasis occurs in about 5 to 15% of patients who are undergoing cholecystectomy. And currently, there are two management approaches for patients with choledochal lithiasis. The first is a one-stage approach with a laparoscopic cholecystectomy and a common bile duct exploration being performed at the same time. In a two-stage approach, laparoscopic cholecystectomy is performed with either a pre- or post-operative ERCP. Now, two-stage management is the most widely utilized management approach, despite growing evidence of the advantages of the one-stage approach. Several studies have shown there are advantages with one-stage management, including shorter hospitalization, reduced costs, and all of this with similar clearance rates to the two-stage approach. However, the two-stage management approach is not without its risks, especially those attributed particularly to ERCP. And this is in terms of post-operative or post-ERCP pancreatitis, post-ERCP hemorrhage, and infection. Now, despite this, the usage of common bile duct exploration has continued to decline over the years. In tandem, robotic technology is increasingly being implemented in the management of general surgery, emergency general surgery patients. And the advantages with the robotic platform are that it offers enhanced visualization and freedom of movement compared to traditional laparoscopy. And these can be advantageous in particularly difficult dissections and facilitate a common bile duct exploration. Now, it is unclear if common bile duct exploration that's performed with a robotic-assisted laparoscopic cholecystectomy is achievable and safe. Thus, for our study, we sought to evaluate the utility of performing transcystic common bile duct exploration during robotic-assisted laparoscopic cholecystectomy compared to traditional two-stage management. And our primary outcomes of interest were time to the clearance of the common bile duct, clearance rates, postoperative length of stay, and total length of stay. For our secondary outcomes, we were interested in radiation exposure, which breaks down into the fluoroscopy times and the total radiation dose each patient received, as well as procedural morbidity, complications, and readmission rates. For our methods, we performed a retrospective chart review between May of 2022 to December of 2023. Patients were divided into the one-stage management and two-stage management groups. There was no randomization here. This was dependent on surgeon preference. For the one-stage management group, inclusion were adults who had a suspected diagnosis of choledochal lithiasis and underwent a robotic-assisted laparoscopic cholecystectomy and a transcystic common bile duct exploration, and these were all performed with a choledocoscope. For the two-stage management group, these were adults who had a suspected diagnosis of choledochal lithiasis and underwent a laparoscopic cholecystectomy and the ERCP during the same admission. The patients were excluded from each group, as you see here, and the most common reasons for exclusion were alternate pathologies that were identified during the common bile duct exploration or the ERCP, or two procedures occurring in two different admissions. So this left us with 53 patients in the one-stage management group, 105 in the two-stage management group, and then we further divided the two-stage management group into those who got their ERCP first and then proceeded to the OR, and then those who had their laparoscopic cholecystectomy first, followed by the ERCP. So here are the demographics for the one-stage and two-stage groups as a whole. And across the board, there was similar representation for age, sex, race, ethnicity, and the BMI. There was also similar representation across all of the comorbidities listed on your right side. We also looked at preoperative labs for all of these patients, and again, there was no significant difference in the preoperative workup for these patients. And to note, the common bile duct diameter at the bottom was taken from right upper quadrant ultrasounds. So for the meat of our study, for our primary outcomes, we found that the time to common bile duct clearance was shorter in the one-stage group. Post-operative length of stay and total length of stay was also significantly shorter for the one-stage group compared to the two-stage group. And in terms of secondary outcomes, there was less or a lot less, I guess, radiation exposure in the one-stage management group compared to the two-stage management group. But clearance rates, complication rates, and the 30-day readmission rates were the same for both. We then subdivided the two-stage patients into the ERCP first or ERCP second groups and performed the sub-analysis because the timing of the ERCP may be affecting our results. And what we ended up finding was that for time to common bile duct clearance, the one-stage management group did have a shorter time to clearance compared to the ERCP group that happened after the OR, but not for patients who received the ERCP first in the two-stage management group. But across the board, the post-op length of stay and total length of stay was still shorter for the one-stage patients compared to the two-stage patients. So in summary, compared to two-stage management, one-stage management had a reduction in the time to common bile duct clearance, especially for the group or the subgroup that got their ERCP second. They also had a lower post-operative length of stay and total length of stay. One-stage management also reduced overall radiation exposure, and clearance rates, procedural, morbidity, and readmission rates were similar between the management groups. So in conclusion, robotic-assisted laparoscopic cholecystectomy with transcystic common bile duct exploration is a safe and feasible option in the management of choledochal lithiasis. And I guess the last bits for this are that we are going to be performing a cost analysis for this project just to assess total cost for the hospital, but how much the procedure is actually adding to the hospitalization for those patients who are undergoing the robotic-assisted procedure. All right, thank you, and I'm happy to take any questions.